So I'm going to be discussing the role of covered stents and debating in favor of them in favoring dialysis access. Those are my conflicts of interest. There have been numerous discussions and debates and presentations so far, and those are the main modes of action against myointimal hyperplasia in failing fistulas and grafts. We've got covered stents, we've got bare metal stents, we've got drug-coated balloons favoring paclitaxel in the first randomized studies, and cutting balloons, high-pressure balloons. You're going to hear a lot more from the next speakers. This is a meta-analysis we published back a few years ago, and I think it very nicely illustrates a consistent benefit in terms of improvement of patency with the use of cutting balloons at the top, covered stents in the middle, and paclitaxel-coated balloons at the bottom. So I'm going to be showing you all the evidence, strong randomized evidence in favor of the covered stents in particular. Let's have a look on the K-doc first. Have a look, there are specific recommendations that recommend the use of stents for the failing graft vein anastomotic segments. And at the very, very bottom, I will highlight that there is an expert opinion discouraging the use of bare metal stents, and I think pretty much the whole meeting here echoes the same opinion. So first randomized study published in the New England Journal of Medicine. Ziv Haskell has paved the way there, 2010. 190 patients randomized with a stenosis at the venous anastomotic site of a stent graft device. The Fleurbaud stent was used, short, very, very short lesions as expected. Primary endpoint set at 6 months. So this was pretty much the very, very first compelling piece of evidence, nearly twofold increased patency with the use of the covered stent against plain balloon angioplasty. Have a look on the actual results, 51 versus 23%, 38 versus 20% at the bottom for the whole circuit. Very, very compelling evidence, and I think that pretty much set the foundation for the progressively increased use of the devices on that anatomical segment. Then came the revised randomized study, published 2016. This was quite a large study, 293 patients. This was with the use of the Viaband stent. There was something particular in this case that they enrolled either dysfunctional or already thrombosed hemodialysis grafts, so a pretty much more challenging patient population. And again, primary endpoint set at 6 months again. This is the outcome, the main endpoint out to 2 months' time, and you can see how the curves are consistently apart. Highly significant result. Again, median patency pretty much twofold, 2 times better with the use of the covers than the venous anastomotic site. Have a look on the subgroups in terms of the stenotic and the thrombosed groups of patients. I have highlighted that, and you can see a consistent benefit with the use of the covered stent in both of those cases. There is another one, the Renova study, 2-year results from Ziv again, large multi-center long-term study, 191 patients. We've got results in this case now out to 2 years. The baseline demographics were balanced, very much in line with the New England Journal of Medicine publication. And moving on to the results immediately, this is quite an impressive, compelling and consistent and very, very durable result, I would argue, out to 2 years. Of course, there is catch-up of restenosis and loss of patency in both groups, but the advantage benefit seems to hold in the long term. At the very, very bottom, I have highlighted the median number of interventions, 2.5 times in the active intervention arm compared to 4.0 in the control arm. So a significant benefit in favor of the covered stent group. Now, may I remind you that those stents come in a number of configurations, and you get the straight ones and you get the flared ones, and you can try and size them according to basically to the diameter of the outflow vein. There is even a meta-analysis with the use of covered stents for the failing synthetic grafts, and again you can see this consistent benefit at 6 months, 12 months, 24 months, ranging from 2 to nearly 4 times better patency with the use of those devices. Now, what about the native fistulas? And this, at the beginning, sounded a little bit provocative. Everybody is in favor pretty much of a leaving nothing behind strategy in the native fistula. fistulas, but we might have to think again. I have highlighted the most frequent site of stenosis, juxtanastomotic in-circuit stenosis, very, very typical sites. And we've got the Avenue study. About Dormats has already shown that. The Avenue study is a prospective multinational study. 208 patients have been randomized. There has been already the demonstration of the 2-year results at CIRSE last year. I will highlight the predominant location of the lesions in the cephalic arch. So this study, I would argue, mainly refers to the cephalic outflow and the cephalic arch itself, not so many lesions located in the more proximal parts of the fistulas. And again, a very compelling result. At 6 months, at 6 months time in the middle, you can see a nearly twofold better patency, out to 1 year again, more than double the patency outcome. And have a look on the long-term results out to 2 years, nearly 4 times better in the case of the covered stent placement for the treatment again of native fistula stenosis. So I think in conclusion, there is consistent, compelling randomized evidence to support the use of covered stents for failing thrombosed, dysfunctional synthetic grafts or failing stenosed arteriovenous fistulas, and of course also the indications in case of an emergency case. Thank you very much.